Hi, everyone. I hope your morning has been filled with meaningful learning and connection with our speakers, exhibitors, and with each other. As we move into the next hour, we're turning our attention to a topic that has rightly received national focus, the alarming rise in early onset colorectal cancer, meaning colon or rectal cancer diagnosed before the age of 50. Did you know that colorectal cancer is now the leading cause of cancer death for men under 50 and the second leading cause for women under 50? According to the American College of Surgeons, people born in 1990 face nearly double the risk of colon cancer and quadruple the risk of rectal cancer compared to those born in 1950. But behind these statistics are real people and real stories. Today, it's my honor to invite Sage Collins to share hers. Sage's journey begins with an unexpected diagnosis at just 32 years old. Through treatment and resilience, she has emerged with a message that reminds us why we do this work. So we're going to pause and watch a brief video that shares her powerful journey.
We wanted to start a family shortly after getting married, and it just felt so special and so right for that time of our lives, and we were just elated, over the moon. While the pregnancy itself felt smooth and easy, I felt like my body, something felt wrong. After I had Asher, I remember being so sick that I couldn't even play with him. I couldn't do anything that a new mom should be able to do with their kids. And I said, this is no way to live. So that's when I really started to seek out the answers. You hear the word cancer and it almost just feels like a bullet. Especially being young, especially having a young family. I remember saying, I don't want to die, I can't die, I'm a mom.
When I see young parents, young moms especially, knowing that someone's at that stage of life where you're supposed to go, this isn't what you're supposed to be focusing on right now. This isn't supposed to be this decade. It's always a little shocking, and it's always a little gutting. And then you go, okay, what are we gonna do about it?
Hi, how are you? I'm good. I remember she walked into the room and I was like, I feel like we are two kindred souls. I feel like we are going to be a really good team together. I do. It was such a embarrassing.
She was all in with a positive attitude and, just ready to go for it.
My care team at UVM was remarkable. They were so on top of my case especially and so knowledgeable in my disease that I felt like I almost didn't have to do any of the thinking.
The fact that we have both the academic setting where we have experts who are able to focus on specific diseases and to have that closeness is what I think is really special about taking care of patients in Vermont.
I was able to go home after those treatments, recover, sleep, relax, have my friends and family nearby. Having them in such close proximity made the recovery process so much easier for me.
We love celebrating wins. We love big wins, we love little wins. We're ready to celebrate and enjoy the time that we wouldn't have had otherwise.
Good, how are you? So good to see you. Cancer. It is such a scary word, particularly with a late stage diagnosis. There's a very common misconception that it's a death sentence. Now I understand it to be such a unique experience for each individual. I remember looking at Asher and I said, I am not gonna miss you growing up. You are going to be the reason why I beat this, and I'm going to have such a cool story to tell you someday when you're older and you can understand what your mom's been through. You're goofy. You're goofy.
We don't know for sure if this is gone for now or forever. If it comes to a point where we have to do something else, we will be there and ready to go.
So it is my great pleasure to introduce Sage Collins up to the stage, who will be welcoming our keynote speaker.
Hi, everyone. Give me a minute to recover after that. I've seen that video probably 5 or 6 or 10 times now, and every time it makes me emotional. It is a true honor to be here today and to share my story with you all. As you just saw from that video, I was diagnosed with advanced stage rectal cancer in March of 2024. Despite months of symptoms that became increasingly concerning, I still lived in a world where I was untouchable by the word cancer. I'd seen the statistics. I knew it was becoming more prevalent, but surely not me, right? It wasn't until my body began screaming, pleading, for me to find answers that I finally heard the diagnosis that I'd been so scared of. And yet, despite all of the glaringly obvious signs, I didn't see my diagnosis coming. Up until the moment that I was diagnosed, I was still holding out hope. Maybe it's IBS, maybe it's an ulcer, anything but cancer. After all, this cancer was reserved for those of an older age and generations beyond my own. But there I was in a hospital gown after my very first colonoscopy at the age of 32, with the reverberating words, "It's cancer." Once it sank in, my entire world shifted. I found myself asking, what care do I need as a mom? I'm a mom, I have a baby, I can't die. What care do I need as a 32-year-old woman? And trust me, I know these questions look different for everyone because everyone's experience is unique. I have to give credit to Molly because at no point did she share statistics or prognosis with me. She let my journey become my own story, my own ending, and I was determined to make it a happy one. I'm deeply grateful for the personal guidance and care I received at the UVM Cancer Center. I'm thankful to be here today. I'm thankful to have watched my son turn 1 and then watch him turn 2. I'm thankful to have taken several trips, made many friends, and made countless more memories. In this new phase of life, in survivorship, I find myself asking new questions. How do I live with cancer from here on out? As a patient and as a mom, what does the future hold for me, my son, and our family? While some answers remain unknowable, many can be found through research. The researchers here today, thank you. Thank you for your discoveries, your creativity, and your resilience. We as patients are counting on you. One of these researchers is Dr. Benjamin Schlechter. Dr. Schlechter is a physician and a researcher at the Gastrointestinal Cancer Center at Dana-Farber Cancer Institute in Boston. He is actively leading clinical trials in GI malignancies and developing new approaches to immunotherapy in colorectal cancer. He also serves as the Harvard-wide principal investigator for multiple cellular therapy trials for GI cancers. This Sunday, September 21st, I turned 34 years old. When I received my diagnosis, I wasn't sure I would even live to see 33. So, here's to this next year, to many more birthdays, to many more celebrations of life, just because. Dr. Schlechter, thank you for your work to ease the burden of cancer for patients today and for generations to come. It's my pleasure. Please welcome Dr. Benjamin Schlechter.
Well, thank you for having me. I'm going to just advance the slides if I can do this successfully. All right. So we're going to talk a little about the numbers, not about the humans. I'm going to describe a problem, and I think that's actually that's a tough act to follow, and I think it's I'm hoping that we can end on not just describing the problem of young onset colorectal cancer, but thinking of some solutions. The solutions I deal with as an oncologist are interventional solutions. I think the other solutions that we have to think about that other investigators are working on, even within the funding crisis we all now face, is interception and prevention. And hopefully some of these observations on young onset colorectal cancer can help identify those things. So my disclosures, I'm on the advisory board of Agenus, and I will mention published data from that as well as AstraZeneca. So we're going to talk a bit about the background of colorectal cancer, the incidence in young onset colorectal cancer, outcomes in young onset colorectal cancer, the genes, the genomics, what's different about these things genetically, and some of the associations, and then maybe some solutions that I can think of. We should always start with a case. So the case that I'm going to talk about is one of my patients named Sophia. She's a 42-year-old woman who presented with pelvic pain and anemia for 7 months. Her anemia was attributed to menorrhagia, so irregular and heavy periods, and a uterine fibroid. And after 3 presentations to the emergency department, finally a CT was done, and it revealed a mass in the upper part of the rectum, the rectosigmoid junction. A colonoscopy showed a high rectal cancer, and a biopsy confirmed cancer, adenocarcinoma, that was microsatellite stable, sort of standard rectal cancer. She has no family history of malignancy. She's a never smoker. She's a healthy young woman who's the primary caregiver of her elderly mother. She received an upfront therapy, neoadjuvant chemotherapy, with the hope to shrink her cancer with the addition of radiation therapy. It was at the height of the pandemic, so we did what's called short-course radiation. She had successful surgery, which revealed a relatively large tumor, T4N0 cancer, with no residual disease left behind. And approximately 1 year after surgery, she developed recurrent disease, in the peritoneum, which is a sort of dreaded complication of colorectal cancer with some of the worst outcomes. She received a chemotherapy called FOLFIRI and cytoreductive surgery, which was successful. But 6 months later, again, she had multifocal progressive disease, this time in the belly and in the lung. And we did DNA testing on her cancer, really nothing special. RAS-RAF wild-type colorectal cancer, probably 50% of colorectal cancers would have this genetic profile. This is an example of her scan. So those bright white dots that you see down in the lower part of the belly with the blue arrows, that's metastatic disease in her peritoneum. When you see blue arrows in my talk, those blue arrows are bad news. And in her lungs, on the right side of the screen, you see these metastases scattered throughout many, many, many scores of them. So this was my young onset patient that I wanted to talk about as an example, because I also want to talk about what we're doing. But when we talk about colorectal cancer, I think it's helpful to have a little bit of biology, not too much. It's right after lunch. We all had a lot of carbs. We will fall asleep. But fundamentally, I think it's helpful to have like a little bit of a cartoon in your mind about what these cancers are. So there's a driver mutation, KRAS. We heard about KRAS earlier today. KRAS is critically important. About shy of half of patients have KRAS mutations. They're more common on the left side of the cancer. Until very recently, we consider these undruggable. And Revolution Medicines and some other companies have actually changed that. And that's really, really important, not just in rare targets like G12C, but even G12D and then pan-RAS inhibitors and degraders from other companies. This is important. BRAF. BRAF is a dreaded cancer. This is one of the most motivated colorectal cancers. It invades things, and it's a killer disease. There are now trials that have been successful in BRAF. There's HER2-amplified cancers, a gene identified in breast cancer. Rather than there being internal motivation of the cancer, it has too many receptors that promotes growth, and a number of other types. Most recently, I think the one we can think about is the PI3 kinase on the bottom right there. The reason that's important is curative intent therapy is improving in PI3 kinase as of a New England Journal article yesterday. So things are happening in colon cancer. If we were to look at a cartoon of how this looks, on the outside of the cell, a normal cell is listening to its environment, and there's internal mechanisms that grind the gears of growth, and colorectal cancer mutates those gears. They are always on, and that's what promotes growth and invasion of this cancer. So young onset cancer has the same biology. Young onset cancer currently is defined as microsatellite stable, the standard colorectal cancer, under the age of 50. That is a colorectal cancer that does not run in families. It's not associated with Lynch syndrome. That's a different disease. They may be called colon cancer, but mismatch repair deficient, microsatellite unstable, and Lynch syndrome, that's really a different disease, and we should give it a different name so we prevent confusion. This definition is not a biological definition. We call it young onset cancer because it's younger than the average age of screening. We didn't make a biological distinction. We sort of made a sociological distinction to define young onset colorectal cancer. But there's emerging data that may tell us more about the biology of the younger and youngest patients and how they do and what to expect. I think it's important we talk about screening because screening prevents colorectal cancer. The current screening age, as we saw, is 45. Screening is only meant for average risk individuals. If you have a family history of colorectal cancer, if you have something wrong like bleeding or pain, that's not screening, that's diagnosis, okay? But screening means you don't have a personal history of polyps or Crohn's disease or ulcerative colitis. Screening is for the rest of us. Screening is also effective. Just to give you an example, if you look at the screening rate, it goes up, and you look at the cancer rate, it goes down. Screening works. Like vaccines, which are data-driven interventions, they save lives, and this is very important. The other important thing to know is the best screening test is the one that gets done. So there are many people who would claim that colonoscopy is the best screening test, but adherence to colonoscopy is like, 60%. I would say a test that's not done does not matter. So whether it's one of the interventional blood tests, which might be inferior in some ways, it's better than doing nothing. The stool DNA testing, the poop in a box, for lack of a better term, which is Cologuard, it's a very effective test. And those are important. So feel empowered to prescribe those for your patients. Feel empowered to mention them. I'm the guy at like the high school reunion who's like, have you had your Cologuard? Have you had just your colonoscopy? I might save the life of someone. The updated screening guidelines happened in the midst of the pandemic in 2021. I think that delayed uptake of these colorectal cancer guidelines. Screening now starts at 45. Screening was a very generic recommendation from the USPSTF. Everyone gets a colonoscopy. That may not reflect what's happening, but that's what the recommendation is, and we're going to talk about what's changing. So colon cancer is rising in adults below the conventional screening age of 50, and you can see that blue arrow. There's an inflection point starting around 2000, or if we look at the year of birth, probably starting around 1960 to 1970. Everyone born after that year by birth cohort has an increased risk of colorectal cancer, whereas in the older adult population, or the average adult population, unfortunately the sort of me adult population, that number is going down because screening works, screening saves lives. This is a worldwide epidemic. We look across the English-speaking world, we can see that in Australia, New Zealand, and Canada, the United States, you can see an uptick in age 20 to age 49 adults, young adults are increasing in colorectal cancer and in a dramatic way over time. And you can also see suppression of colorectal cancer in the bottom in older adults because of screening. It's not just the English-speaking world. In fact, it's throughout the entire world, both the industrialized world, the global south, everywhere in the world that you look, colorectal cancer is on the rise, and it's spreading across the world progressively. All colon cancers are not equal. There's left-sided colon cancers and right-sided colon cancers, and there's rectal cancer. So the way you should think of your colon is that everything we ate just now enters the right side of our colon, the cecum, so the entry point of the colon, as wet. It's essentially liquid. And the job of the colon is to extract water until you have solid stool so you can store it, and then stores it in the rectum. And the rectum has complicated anatomy so that it works really well. When you think about the complexity of rectal cancer, we're going to talk a little bit later, the rectum can do an amazing job. If you had chewed food, water, and air in your mouth, and you went head down, you couldn't get the air out. But your rectum can do that. So the rectum is a very complicated organ. Okay? But the rectum is deeply exposed to a concentration of stool. And if we look at what's happening over time, it's the rectum and the left-sided cancers that are rising, not the right-sided cancers. So epidemiologically and maybe biologically, we can learn something from this finding. The left side of the colon, the dry side of the colon, the rectum, the driest part of the colon, is where we're seeing the most of the rise in cancers. This is happening across all ethnic groups, but it is also, with one exception, was the Asian Pacific Islander population. We'll see, I bet you they're going to catch up soon. Importantly, rectal cancer is complicated and anatomically, rectal cancer is getting more of these cancers. In fact, you're 4 times as likely to get this as opposed to 2 times as likely as the rest of the colon. So the colon is one organ, the rectum is another. This is biased towards the left side of the colon and the rectum, which is what we heard in Sage's story. Rectal cancer also has worse outcomes, worse survival outcomes. Rectal cancer accounts for 1/3 of all colorectal cancers, but 45% of deaths from colorectal cancer. So it's anatomically complicated and outcomes are inferior. When we look across mortality in colorectal cancer, we can also see the impact of screening. Older adults have a nice, effective linear decline in mortality from colorectal cancer, but younger adults, it's rising. If we look across time, across all cancers, you can see virtually every cancer, it's moving down. In this day and age, more than 2/3 of all cancer diagnosed are cured in the United States. And then there's the blue line, which is colon cancer, which is rising, and we're not suppressing mortality any longer because of the impact of young onset colorectal cancer. And in fact, as of now, for cancer deaths, the leading cause of cancer death in men is colorectal cancer. And by 2030, colorectal cancer is estimated to surpass breast cancer as the leading cause of cancer-related death in the United States. The other thing that we've noticed is that if we look at our predictions and who's getting cancer, it's not just young onset colorectal cancer, it's youngest onset colorectal cancer. So whereas colon cancer you can see is rising, and if you look there, and that's a 90% increase over time for the 20 to 34-year-olds, but only a 27% increase over time, 35 to 49-year-olds. It's biased towards younger patients. Rectal cancer is even worse, 46% increase in the 35 to 49, more than a doubling in adults under the age of 35. Again, part of Sage's story. Colorectal cancer is diagnosed more late and more advanced. 41% of patients waited 6 months to seek medical attention. 67% of patients saw multiple physicians before diagnosis. And 71% of patients are diagnosed with stage 3, locally advanced, or stage 4, advanced disease. A subset of stage 4 is curable disease, but we don't want to diagnose locally advanced and advanced disease. We want early cancer. We want to intervene at the most curable time points. Young onset colorectal cancer patients receive more aggressive therapy. You're more likely as a young person to receive multi-agent chemotherapy. And this begs the question, we do that because we have this hypothesis that young people can take it, so let's do more. But that doesn't appear to be changing outcomes. If we look at the advanced disease population, survival for younger onset and average onset patients is identical. And in fact, if we look at the youngest onset patients, the teenagers to 35-year-olds, they appear to have even inferior outcomes. If we look at survival, you can see that the survival in older adults will be 26 months for median survival for advanced disease and 21 months for younger adults, and so forth. Each point that we get along, it gets a little bit worse. And if you look at stage 2 and stage 3 disease, respectable disease, the benefit of adjuvant therapy and curative intent therapy is inferior for the youngest adults. And so we have to think about this for a second. I think this is a profoundly troubling problem. I think it's also troubling that we're giving more chemo for no additional benefit. And I also think that younger onset patients may suffer a little bit more. And I can't give you data on this, so I didn't put a slide on it. But think of this. In a younger adult, their tumor is 6 to 8 years old from inception. And in an older adult, their tumor is 6 to 8 years old from inception. In a 35-year-old, your brain is 35 years old, and so are the blood vessels. And in a 70-year-old, your brain's 70 years old, and so are the blood vessels. So the penetration of chemotherapy into a younger patient's tumor and an older patient's tumor is actually probably similar. The penetration of chemotherapy into normal tissue in a younger adult is actually probably greater. And so I worry, as I am part of the young onset program at Dana-Farber, that younger onset patients derive the same benefit but more toxicity than older adults. I think we need to study this. I can't prove this to you, but it keeps me up at night. As we think about the impact on patients, we need to really think about rectal cancer in particular, and the paradigms are shifting. We're not just focusing on cure but quality of life. And this is a really important study called the Prospect Study, which was led by Deb Schrag at Dana-Farber, now it's Lynn Kettering. This asked the question, if we have better chemo, do we have to expose patients to pelvic radiation? And the answer was no, that 91% of the time with high-quality chemotherapy, we can avoid the injury of radiation, that patients can receive chemotherapy and radiation therapy and surgery without radiation, which results in better quality of life, better bowel function, more likely to preserve fertility. We're talking about a population at their maximum productivity economically, they're caregivers for children, they're caregivers for their parents, and they want to have families. And so thinking about paradigms for care that doesn't jeopardize cure and preserves these important quality of life metrics is valuable. And so Prospect asked that question. On the flip side, we have the PRODIGE study. This actually said, is more chemo more better? It says yes, more chemo may be more better, but the problem with this clinical trial is it's confounded by a third of patients in the control arm didn't get the planned therapy. So more chemo is more better if the control arm didn't get any chemo at all. So I actually don't know if we know if more chemo is more better. We'll see. And then finally, there's the OPRA trial. This is a really important trial in rectal cancer. This is the population we're talking about. OPRA stands for organ preservation and rectal adenocarcinoma. This is a bit of an overpromise. It's sort of opportunistic and occasional organ preservation in rectal cancer because most people can't preserve the rectum, but many can. And this gives us an option of avoiding surgery in a quarter of individuals, and that's really, really valuable. So how should we think about these patients? Are these same disease, just younger? Are these biologically different diseases? Is this a different disease? So we had a lot of data come out over time looking at different genes, and everyone gave a different story about the genetics of younger onset colorectal cancer. And I will tell you, as an investigator, nothing scares me more than someone I respect saying it's this, and then someone I respect saying it's that. That's problematic. And so when you look more closely, we have some recent data that came out at ASCO a couple years ago, groups in France and Colorado and Canada, and they consistently showed the same thing, which is that younger onset patients are more likely to have increased mutations in a gene called KRAS. We've heard a lot about KRAS today, acquired mutations in APC, and they're less likely to have a mutation called RNF43. RNF43 is kind of an important member of the Wnt pathway, and they can have this mutation called POLE. The reason POLE matters is it may be a target for immune therapy. So maybe there is something different. Now, we recently had a clinical trial, or not recently, I should say, we had a clinical trial published called SWOG 80405. That is a seminal trial of chemotherapy plus a drug called bevacizumab versus a drug called cetuximab. It was published in 2007. And so we have archival data from that trial that was saved at the NIH as part of our cooperative clinical trial, the value of investigation. And when we did next generation sequencing, DNA testing on these patients, and we were able at that time to look at race, we could look at black patients versus white patients, we observed a mutation profile, increased mutations in KRAS, increased mutations in APC, decreased mutations in RNF43, which was the same thing that we heard in a modern data set, a present data set of colorectal cancer. And so it could be what we were seeing was not that different good investigators were finding different things, but when you test matters and who you test matters. Because the similar profile seen in black patients of 2025 and white patients of 2003 implies something is happening, that there's an exposure that is expanding through society that probably started in underserved and urban population and is creeping through the United States and through the world. And so these investigations matter, and defining who we're investigating matters, and when the sample comes from matters. If it's an environmental exposure, a time point is not good enough. Time points matter. There's other things that we know. We know that obesity matters. We know that obesity is bad for all cancers. But this is interesting. This is from the Nurses' Health Study, looking only at women. And what we can see is that major weight gain after the end of adolescence is associated with increased colorectal cancer. I can't explain to you why this is, but it's not just that if you're always heavy, it's that if you're skinny and you get heavy, you have a problem. Or if you're heavy and you get a lot heavier, major weight gain is a problem. Behavior, okay? Lots of people like to talk about video games. Well, so we use video games as a proxy to try and understand sedentary behavior. And it turns out that the people who spend the most time in front of TV as a child are more likely to have young onset colorectal cancer. That's probably not the effect of TV. The hypothesis is that essentially kids who play a lot of video games and sit in front of the TV probably sit longer constipated because they're holding it in to get in the next show or kill the next dragon. And that may have biological problems like impaired glucose metabolism, decreased exposure to the sun, and vitamin D exposure, and sort of you're marinating your young colon in toxins. We also know that sugar-sweetened beverages in childhood are associated with increased young onset colorectal cancer. So the kids who drink the most sugar-sweetened beverages are most likely in adulthood to have young onset colorectal cancer. Again, the hypothesis being that sugar-sweetened beverages may result in excess sugar in the gut and bacterial overgrowth. The microbiome may be altered in some way. Now, this is a troubling one, and this was actually, I think, very hard to publish because it's easy to be a soundbite and to misinterpret. This is not a knock against breastfeeding, but it's an observation that babies who are breastfed are more likely to grow up to be adults with young onset colorectal cancer. So that it implies that this is an exposure that starts very, very early in life. Younger adults with polyps are more likely to have been breastfed. Younger adults with colorectal cancer are more likely to be breastfed. And it tends to be biased towards the distal colon. So what's going on here? Maybe it's microbiome. This was a recent publication in Nature. You can see this was actually when it was still the preview of the publication in Nature when I did the screenshot. This was a microbiome study looking at a strain of E. coli throughout the world, but not the United States. So we have some caveats in place here. And there was a mutational profile that was produced by a toxin produced by this E. coli strain. And you could find that mutational profile in 25% of young onset colorectal cancers. So microbiome does not explain it, but explains part of it, that there's something out there, that there's an injury that's coming from bacteria. So how should we interpret these data? Rectal cancer versus colon cancer, we have a racial time bias, we have obesity, we have lifestyle, we have sugar-sweetened beverages, we have breast cancer, breastfeeding. So I think that the dry storage effect matters, that the diluted substance in the right side of the colon, whatever it is, it's being concentrated as we remove water. It's probably something partially soluble in water that maybe is then transformed in some other way. The time bias is really important. There's a sociological, socioeconomic effect that is creeping across society that we're all being exposed to. First, some people get it, now everyone gets it. That's why understanding socioeconomic factors and determinants of health matter. Obesity is an inflammatory state, inflammation probably matters. Sedentary lifestyle, changes in motility probably matters. Microbiome, I think that the microbiome changes are probably with the sweetened beverages. That's my speculation, I haven't proven it, but it matters. And breastfeeding tells us it starts really, really early, and we have to start looking hard for these things. Breast milk is really a concentrated water substance. Just like your poop starts as water and becomes a solid, your breast milk starts as plasma and becomes breast milk. And so water is removed to make a concentrated substance. There's something partially soluble going on there. The good news is, vitamin D may be protective. We don't know yet if therapeutic interventions with vitamin D can help, or if those with higher vitamin D because of lifestyle are doing better, but it's worth knowing that there's some hope. But fundamentally, and we're going to talk about some more hope in a second, I promise. But fundamentally, this is a complex problem. There's a combination of environmental exposures, lifestyle exposures, microbiome exposures. There does not appear to be a genetic exposure. This is not parents doing it to their kids genetically. This is a disease of the innocent, but it's from exposure and injury to the DNA of the patient. So Dana-Farber, who led where I came from, who sort of pioneered the development of chemotherapy in the United States, he sort of made the statement that he's never accepted the incurability of cancer, and he remains hopeful that we can find answers to colorectal cancer, to all cancer. This guy was a pathologist. He wasn't a pediatrician who treated pediatric leukemia. He was a pathologist looking at blood and said, you know what, I think I can do something about this. So let's get back to our case. This is Sophia's scan. You can see here where I have the angry blue arrows that she has cancer in the peritoneum, she has cancer in the lungs. And so she's this 42-year-old woman. She had 3 evaluations in the emergency room for pain, anemia, and bleeding. She was ultimately diagnosed with locally advanced rectal cancer. She received total neoadjuvant therapy with short-course radiation followed by FOLFOX. She had successful surgery, but the cancer came back anyway. Every time a surgeon says, I got it all, an angel loses their wings. She received FOLFIRI chemotherapy and cytoreductive surgery, and it came back again. And 6 months later, she has multifocal metastatic disease in the peritoneum and lungs. So she was treated with chemotherapy with panitumumab, an EGFR inhibitor, FOLFOX rechallenge, and then trifluridine tipiracil bevacizumab, the brand name of it as Lonsurf, if you're familiar. We considered for a trial of botensilimab with balstilimab. That's the Agenus product I'm going to mention briefly. And she ultimately enrolled in a phase 1 clinical trial of CAR-T. Botensilimab is currently not available in the United States. Botensilimab and balstilimab is really interesting. It's the immune therapy we've been hoping for. It's a modified CTLA-4 inhibitor. It's not just IPI or TREMI. This is a new drug that works in new ways, but it's a cousin of those drugs. And we showed, published in Nature last year, that for patients with colorectal cancer outside of the liver, they can have profound, deep, and durable responses with hyperrefractory disease, even those who have received FOLFOX, FOLFIRI, bevacizumab, panitumumab, cetuximab, trifluridine, regorafenib, fruquintinib. We presented at ESMO in July that even the hyperrefractory patients do as well as the standard refractory patients. So we got to get this drug into people. We just have to find a way to get it to people. So CAR T is the other thing that Sophia is now being enrolled in, and she has actually been successfully treated on a CAR T trial. I'm going to explain this very briefly, okay? Because you get an investigational drug doctor up here, we'll talk a lot. Fundamentally, a CAR T takes the mechanism, the engine of destruction from a T cell. What was the death kiss or something like that was the talk you were saying? That was a fantastic description. So takes that kiss, and we engineer the kiss. We choose where the cell goes, and we strip away the regulation. There's no transmission in a CAR T. It's a non-physiologic T cell. It will continue to work no matter what. And so the inflammation is instantaneous and persistent. The problem with the CAR T is it's not very smart. It goes where you point it. And the problem with colon cancer, the dirty little secret of colorectal cancer and of most solid tumors, is they're deeply similar to normal tissue. The cancer derived from you looks just like you to the immune system. That's why you have cancer at all. And so it's been a real challenge to find targets present in colon cancer that are not present on something else. So we do the Harvard thing. You have a protein, we'll call it Schlechter-1. If I find Schlechter-1 on everyone's colon cancer and I create a CAR T against it and Schlechter-1 is present on my brain, that CAR T will consume my brain at the same time it consumes my colon cancer. So really, we have to be careful. So we have a clinical trial called GCC19 CAR T. This is a product developed in Shanghai and brought forward to the United States. We've treated 12 patients. We just completed our phase 1 trial. We're waiting for approval to move into dose expansion. So this is a really weird CAR T, okay? You have a cancer cell. Colon cancer has this marker GCC, guanylate cyclase C. Guanylate cyclase C has been known since the 70s. It's present from your nose out your butt, and it's present on your colon cancer. So what we also know is that CAR T fails in solid tumors. Numerous CAR T trials have been negative. They fail because the environment of cancer is toxic to T cells. And we know some of the hormones that we need to promote survival of CAR T cells, and so we can engineer it. We know that we need IL-6, we know we need IL-12, we know we need interferon gamma. So what we can do is create not just one CAR T, but many. There are 4 different viral vectors that go into the blood product from this patient to generate the CAR T cells, which means a mishmash of cells come out. Most of the things that come out are this little blue guy, the GCC CAR. That's a CAR that will stick to GCC in a colon cancer cell and kill it. It could also stick to your colon and kill it. We have to be careful. And then there's a small number of those other CAR Ts, the yellow guys there. That's a CD19. CD19 is a blood cell. And so you can put that CAR in someone, and it will consume those blood cells and produce hormones. And a really small number of these cells have a little bit of GCC and a little bit of CD19, which means that that CAR cell binds to the tumor cell next to the cancer-killing GCC CAR, but that double CAR is making hormones. And those hormones support the activity of the CAR T so it can achieve a response in colon cancer for the first time. And so we can see that in this patient here, this graph on the right. So you can see when the patient gets her CAR Ts, it's at 100%, and very quickly it descends to 0%. And that's what happens with every solid tumor CAR. The drug companies want us to think it localizes to the tumor, but as far as I can tell, it localizes the tumor and dies. But then this thing swings back up, and that's new. What we can also see is that the CD19, the yellow CAR, the hormone-producing CAR, shoots up, and we would expect that because there's lots of blood cells around to feed off of. But that double, the green, blue plus yellow equals green, that's how my brain came up with it. The blue plus yellow equals green cells that are a little bit of each, they shot up, and they survived a little while, and then they kind of collapsed because it's not good to have that many CAR insertions. So those are not very healthy CAR T cells. And we saw a benefit that we could get cells to descend into the tumor, reflex off, sort of gravity assist off of the CD19, and then maintain and erode the cancer. And that's what we saw. So there's a lot of details in a phase 1 trial, but we got to an effective dose of 2 million cells per kilogram, at least we think we did. And you can see that as this graph here is 5 patients, we now treated 6. You can see one patient on the left, it's red, it grew. Everyone else on the right, it shrank. It did some interesting stuff too, because they didn't shrink fast. The lymphoma doctors are lucky. They give someone a CAR T, and a month later, the patient's disease-free. The GI oncologist, we give someone a CAR T, and 10 months later, they're disease-free. So these are different products. And as you can see here, we have 2 patients where they had 100% reduction of their cancer. There's some details about each of these patients, but you'll also see that there's one on the right is yellow, because that patient died of a complication of the trial. So these are still investigational, And we've worked really, really hard since that patient died to fix the trial. No one has been injured since that time, but these are dangerous first-in-human trials. So if you look at Sophia's scans, and when I say these are hot off the press, this is a scan from August 12th. I actually saw her on Wednesday in clinic, and she's doing great. So on July 1st, she had greater than 100 lung metastases before she received her CAR-Ts. And you can see on August 12th, there's a substantial reduction in size and number of lung metastases. The busyness of those lung fields, if you're good at looking at these, they look less busy. Her CA has dropped. She feels good. So I think there's hope for immune therapy, not just to describe that we have a problem, but maybe to come up with new treatments beyond chemotherapy. So my conclusions for us is this. So young onset colorectal cancer is on the rise. Young onset colorectal cancer is the leading cause of cancer-related death in men under the age of 50, and it's going to surpass breast cancer by 2030, and that's a warning. These are usually left-sided cancers and rectal cancers, and they're usually locally advanced and advanced disease. I think this speaks to this biological effect of dehydration and exposure that's concentrated. We give more intensive therapy to young onset patients, but we haven't proven that's beneficial. I think we have to begin to study younger patients the same way we study older patients as an age group who needs special investigation. Whatever the environmental exposure it starts very early in life. We think obesity, not obesity in childhood, but actually the acquisition of obesity throughout adolescence and young adulthood is related to the risk. Young onset exposure to dietary sugars, breastfeeding, sedentary lifestyle. These are genomically distinct cancers. They're not that distinct, but they're distinct. They may look like cancers from a while ago in an underserved population. And I would also say that vitamin D may be protective. I wouldn't oppose someone taking vitamin D. You can get vitamin D from the sun, and that kills a lot of issues, right? Less active, more vitamin D, sort of everybody wins. And I would say there's hope, a lot of hope, because we have research and we need funding. Now more than ever, we need funding. 98% of all FDA-approved drugs, according to the New England Journal of Medicine, 98% of all FDA-approved drugs, the foundational science was funded by the United States federal government through the NIH grant program. And it's really important that that's being undercut now. Dana-Farber, which is one of the 3 cancer institutes at Harvard, 50% of all modern cancer drugs came out of investigations being done at Dana-Farber. That's a number we're really, really proud of. We're now facing an era in which billions of dollars in funding are being withdrawn from cancer centers like us, like you, and like everyone else, and there's an impact on that. So it matters now that we're doing this research. It matters more than ever. We've identified a problem that we complete the research. So thank you very much. There's a lot of people to thank for this type of work, but mostly we should thank our patients. Yeah, and we can do questions for sure.
So we have a couple minutes. If there are any questions, I will walk back to you. Otherwise, people can feel free to go up to one of the mics if you have a question as well.
Hello, thank you for this amazing presentation. So you mentioned that more intensive chemotherapy in this population didn't necessarily produce better outcomes. Do you have any thoughts or opinions on metronomic or low-dose chemotherapy in these the young onset population?
I think the short answer is we don't know. It's the same issue. Metronomic chemotherapy is the idea that intermittent use of different agents results in upregulation and downregulation of different pathways. The more you push a pathway, the more it goes down, and it becomes less effective. Metronomic chemotherapy, I think, should be subject to the exact same clinical trials as everyone else, and we need to just do the darn work. So I would say my thoughts are we have a lot of work to do, and we have not proven the benefit or lack of benefit of metronomic therapy or really intensification or de-intensification. We just have to study it. Most clinical trials of alternative dosing of chemotherapy have been negative, so there's a certain appeal to escalation, de-escalation patterns, but we haven't proven it to be effective.
Thank you.
I was curious about how, what kind of a fight you had to wage to get this earlier exam covered by insurance
Earlier?
at 45 versus 50,
Yeah, so fortunately the USPSTF, which the United States percentage, United States Preventative Services Task Force. It's like a hard one to say. So they did the work. That's like a really good epidemiologist who looked at the problem of, well, more people have cancer, let's move the age back, and they did an analysis of that. I would suggest, since we now know that cancer is occurring in adults really younger even than that, and it's mostly left-sided cancers, if we think about healthcare utilization, we're worried about colonoscopies. Frankly, since it's mostly left-sided cancers, maybe flex SIGs would get us a lot of the way there. We also need to validate either the blood-based assays, the stool-based assays in younger adults. I'm going to assume that that's being done. I think it would be great if we had a poop-in-a-box assay for younger adults and, frankly, even children. And then there's multi-cancer interception blood tests that are being developed as well to look at methylation in the blood. Every one of those things needs to be investigated. But until they're investigated, insurance is not going to cover them.
So there's two different questions from two different people on Zoom. I'm going to ask them together because
Sure.
they're related. The first is, any thoughts about the role of adequate recommended hydration, ounces per day, on the risk of developing colon cancer? And the second one is, curious about your mention of sugar-sweetened drinks as a cause, wondering about the sucralose and sweetened lows, zero sugar sweeteners, as they relate to the cause of colon cancer.
Once again, I feel so badly. I don't know yet. So sucralose is an interesting one. So sugar-sweetened beverages, we can study in the Nurses' Health Study, so we know that there's an exposure. We can ask about it, and we can learn about it. The sucralose, which is a sweetener that is a sort of a non-digestible sugar, it's also a laxative. Maybe that's a good thing. It can be metabolized by bacteria, and so it may not have the obesity-causing effects, but it may still have the microbiome effects. And so that would be a speculation, but again, we would have to prove it. In terms of hydration, it's hard to know. I think it depends on how effective our kidneys are. Fundamentally, our kidneys are water pumps. And so maybe drinking more really doesn't make that big of a difference to how much, how constipated we are. If you're really dehydrated, you're constipated, but if you're just hydrated or super hydrated, it may make no difference. You just pee out the rest.
Hey there. So as a 90s baby, a female, lots of different stuff like that, I know a major concern amongst my age group is how to access care for these concerns, especially since now it's becoming younger and this seems to be newer research and, you know, we're still learning a lot about it. If you do have concerning symptoms, what would be a good way to start a conversation with your PCP?
You know, it's a hard one for me to answer because I'm always coming to it from the other side of the table. I think the first thing is it's our job as academic oncologists and as advocates and as nurses and as doctors and pharmacists and the patients to make sure our doctors are educated so that when they see a young woman with abdominal pain, they don't say it's fibroids. When they see a young woman with anemia, they don't say it's menorrhagia. I think you have to ask explicitly and say, hey, I am worried about cancer. And, you know, if they're using an ambient AI documentation thing, it's going to say, the patient expresses a worry about cancer, and hopefully the AI will trigger the doctor. Be like, But I think that there's some self-advocacy that we have to happen. There's an education we have to happen. People think of cancer as a disease of the old, not the young, and we just need to change that. And Kimmy Ng, who's here at the top of the list, who's really led this work, Kimmy's like all over the news and talking about it. She's like everywhere, and that's so important that we just talk about poop. Poop shouldn't change. And if it does change, whether it's cancer or something else, you should see a doctor about it.
Thank you.
This is another question on, I'm sorry.
That's okay. Go to the Zoom and then we'll do the question.
Is there a discussion or recommendation to potentially lower the screening age for colonoscopy?
Well, I'm a GI oncologist, so I would say, like, start young. I have to be honest, I gave myself a colonoscopy for my 40th birthday. So maybe I'm not the best person to ask. But I don't know what's going on at the public health infrastructure, but I hope that there will be changes, especially when we have less invasive procedures, stool-based procedures.
This is maybe just more of a reflection. I had cancer, synovial sarcoma, so not colorectal, but I've now gone into social work, and I'm a therapist supporting cancer patients and have come to know and love many folks with colorectal cancer, as well as other types of cancers, those who are still living and those who have passed away. So I do always feel like in these settings, I think it's nice if we honor those folks, as I'm sure you have many that you have cared for who have passed away. But a trend I see that I think is really dangerous to people's mental health is this wondering of why. Why did I get it? How did this happen? So I think as much as I obviously understand the importance of asking these questions of, was I breastfed? Did that matter? Did I gain that much weight after I got out of college? Did that matter? I just want to say that I think like cells also go sideways sometimes, and that like people didn't cause it themselves. So I feel like that's kind of important maybe to like weave into some of these talks, especially when we're in a mixed population setting audience of patients and providers, and obviously a lot of providers themselves are also patients that have had cancer. So maybe if you have any other thoughts on that like I get it in terms of let's prevent, but I think that common message at a lot of these types of conferences cause patients to walk away being like, well, what is my guilt? What did I do wrong? So that's just something I think is
Yeah, I actually think that's an excellent point. And I say this to patients always ask me like, why? And the short answer is, I don't know. Not a single one of these things that I talked about is any individual's risk factor, and none of them are a risk, relative risk of 10 or 100. They're 2 or 3. We're doubling risk. But that's not the only question. This is a disease of the innocent, is what I tell patients. You're a victim of a thing that happened to you. And the same thing when good treatment goes wrong. Bad cells go wrong, good treatment goes wrong. I've given many patients the same treatment, and I can't tell you why sometimes it works and sometimes it doesn't. And I think it is an important point. This is nobody's fault. I think it is the fault of us as an investigational community if we don't figure it out. But I don't think this is an individual patient's fault, and I wouldn't want anyone to come away thinking that. It's a really, really good point.
We're going to have one person at the mic, and then one question on Zoom, and then I think we'll be complete for the session.
Doctor, you've made no mention of an etiology caused by trauma, i.e., and I'm going to be rather graphic here, anal receptive sex. Whether it's penile or a sex toy or fisting. And the second question would be, is there a pathogenic etiology, transmission of human papillomavirus by any linguists and so forth?
Yeah, so rectal cancer and anal cancer are 2 different cancers. So anal cancer is a viral-driven cancer which can be transmitted through sex. But actually, it's usually not. Most people who have anal cancer. It's a virus we all have. If we looked at, there's probably 300 people in this room, 290 of you have HPV, unless you were vaccinated as a child, okay? And you didn't just get it from sex. You got it from water fountains. You got it from door handles and from elevators and from touching things, from being a kid, from being an adult, from being a human being in society. Why it is that we all have HPV, but there's only 3,000 or 4,000 anal squamous cancers diagnosed a year is unknown. Most of the people who have anal squamous cancer never had insertional anal sex. And so I think, unfortunately, the concern that anal squamous cancer, this is a different disease, is related to insertional anal sex and other such things, I think is a vestige of the blame game from the AIDS era. And it really has nothing to do with whether someone had anal sex or not. It purely has to do with the fact that they had a virus and they got unlucky, and in the AIDS era, people were immune suppressed. That's not so true anymore. Colorectal cancer has no known association with HPV. It's not infected with HPV or EBV. It's just, it has a bunch of mutations in KRAS P53 and APC and RNF43 and the Wnt pathway, and has nothing to do with viral infection that we know of. It's, again, a disease of the innocent.
2 questions disguised as one.
Okay.
So do you have a preference with FIT, it's capitalized, or Cologuard, and thoughts on genetic testing? If so, which ones, MSHT/Lynch, and what?
Okay, so I don't have a preference on testing, just get it done. I am an oncologist, so I get you once you have cancer. I'm not an expert on preventing it. So do a good one would be my advice. In terms of DNA testing, so everyone with cancer, in my opinion, should have somatic testing, next generation sequencing. They're all the same, okay? I'm sorry to whoever's out there. They're all excellent. Every one of them is excellent. So every patient should have it. We just talked about this in the advanced disease setting. We're seeing more POL-E mutations. We can treat those patients with immune therapy. Any patient with advanced disease, I think, should have access to DNA testing. I actually think any patient with resected disease should have access to genomic DNA testing. Germline testing doesn't seem to make a difference. It doesn't seem to run in families, but we should do that too, because why not? Why would you want to accidentally not discover that someone's at risk for some other terrible disease. But everyone should be tested, and we now know that in resectable disease, again, as of yesterday, PI3 kinase mutations, the addition of NSAIDs improved curative intent outcomes in stage 2 and stage 3 colon cancer, which means we have to have a DNA test for PI3 kinase, which means we need to be doing these things on patients. So I think my opinion is every cancer patient needs access to somatic DNA testing on their cancer. It is an insurance issue that we have to tackle, but we now have genes that change the chance of cure in colon cancer, published in really important journals. And so I think we as voters, we as patients, we as doctors, we as nurses and pharmacists and advocates need to advocate for DNA testing, both of your family, your germline, and of your cancer for all at all stages of disease.
Thank you so much, Dr. Schlechter. That was, and thank you for totally rolling with us, bringing a Q&A session on you. We have an amazing afternoon lined up. Our next session begins at 2 p.m. and the exhibit hall closes at 3. So please use this time to visit with the community resources here for you today. On the back of your name tag, you'll find a list of the lectures you selected at registration, along with the room for quick reference. If you registered for Living Life to the Fullest by talking about death, the elephant in the room, please navigate to the Sugar Maple Ballroom on the opposite side of the wall via the Fireplace Lounge. If you signed up for What's New in Breast Cancer, please return here. You'll find coffee, tea, and an afternoon snack in the Fireplace Lounge, but before you go, we kindly ask your assistance in keeping the room tidy. Please take a moment to clean up your tables, and we'll see you back at 2 p.m. And apologies, because I think that there's a lot of trash at the garbage cans right here, so there may be some more trash cans that we find if we're running out of space. Thanks, guys.